about the cirrhosis and anesthesia, isn't it?
Yes, sir.
Must have cleared many of your doubts which you must have had yesterday. Anyway, let us just start discussing about some of the doubts, if you have any doubts, and then we will go ahead with pathophysiology because we were discussing about the pathophysiology. So, any doubts you have?
Sir,
Can you? Your friends also might have had some doubts.
actually, it will come for the anesthetic management, sir. So once we are done
Okay,
with
that
the
we will be doing. It's still, we are slightly far away from maybe about 30 minutes or 45 minutes from anesthetic management.
yes,
So
sir.
that we will clear when we come to anesthetic management.
Yes.
Absolutely. So shall we start our discussion?
Yes, sir.
Any other doubts you had for whatever the discussions we had yesterday? In that, do you have any doubts? No, till pulmonary syndrome we had discussed, isn't it?
Yes, sir.
So do you have any doubts regarding till then, regarding the physiology of the liver, anatomy, physiology, because they are very, very important when you are facing an examiner in the practicals, the basics, because as examiners, we always start with the basics. They start asking about your knowledge about your anatomy and physiology of the particular topic. Once you are good in anatomy and physiology and biochemistry and physics, whatever it may be, the basics of anesthesia, we know that you are good in your anesthetic management and you will be safe for the patient as well. So that is why it is very important for us to know more about the anatomy and physiology. That's why yesterday almost more than 1 hour we spent on anatomy and physiology of liver, isn't it? Including the functions of the liver also. Liver has got more than 1,000 functions actually, and all those functions it is very difficult to exactly know. So that's how only few functions we could discuss yesterday. Okay, so till yesterday we actually we were discussing about the pathophysiology of the cirrhosis of liver, and that is end-stage liver disease. And in that we had discussed about the pulmonary pathophysiology. So
Yes, sir.
the pulmonary effects of the portal hypertension. In that we discussed about hepatopulmonary syndrome. We also discussed about the types of hepatopulmonary syndrome. How do you classify the types based on the PaO2? And also we did discuss about the portopulmonary hypertension. Maybe about 15-20% of the patients may develop portopulmonary hypertension. And one thing you should also know that if a patient has portopulmonary hypertension, so it may be one of the contraindications for liver transplantation. So they may not survive. That is why you have to know whether the patient has developed portopulmonary hypertension, especially the severe portopulmonary hypertension when it is more than 45 millimeters mean pulmonary arterial pressure. Because yesterday we discussed based on MPAP or mean pulmonary arterial pressure, you can classify it as mild, moderate, and severe. Anything more than 25 to 35 is mild, 35 to 45 is moderately severe, and anything above 30 to 45 is severe. If the patient has severe portopulmonary hypertension, so he is not a fit candidate for liver transplantation. Because finally, in these patients with decompensated liver disease, invariably they require only the transplant of a new liver, isn't it? Otherwise, they don't survive. So, but this is maybe a contraindication. That is the reason why you have to know about the pathophysiology of, the portal hypertension and end-stage liver disease. And another important thing also we discussed regarding the pulmonary involvement is the platypnea and orthodeoxia. So that is quite contrary to the dyspnea, the patients with pulmonary disease, basic pulmonary disease or basic cardiovascular disease. They have more dyspnea in lying down posture. Unlike patients with liver disease, they may have more dyspnea rapid desaturation in erect posture or sitting posture. So this one common exam question will be asked for you people. So that is the reason why you should know about this particular thing, because of the intrapulmonary vascular or venous dilatations that occur. That intrapulmonary vascular dilatation will produce, suppression of the hypoxic pulmonary vasoconstriction, and also produces increase in the intrapulmonary shunting. So any increase in intrapulmonary shunt will produce an increase in the A gradient, and A gradient invariably will be more than 15 millimeters. Plus, there can be a drop of PaO2. So based on the drop of PaO2, you classify them into different types. If the PaO2 is more than 80, it's mild. If PaO2 is between 60 moderately severe, and if it is between 50 to 60, severe, and if it is less than 50, you call it as very severe. So these are the patients who are likely to have a lot of morbidity and mortality when they undergo any non-hepatic surgeries when they are posted to. Okay, now coming to the cardiovascular system. Can you just tell about what are the changes that occur in cardiovascular system in patients with end-stage liver disease?
Patient will have dynamic, hyperdynamic circulation, which means
Okay.
all the patient is having increased fluid, increased volume of distribution. The intravascular volume will.
No, they'll have hyperdynamic circulation is fine. Hyperdynamic circulation is what? They'll have tachycardia, they'll have, increase in stroke volume, their cardiac output may be the higher side.
Yes, sir.
And there is peripheral vasodilatation. There can be a decrease in the systemic vascular resistance.
Yes.
All these things of hyperdynamic circulation with also a decreased blood pressure.
Yes,
They
sir.
may have a systolic blood pressure of 90 to 100 and diastolic blood pressure of 50 to 60. So what are the causes for the hyperdynamic circulation in these patients?
Because of the deficiency of albumin, there is a
No, nothing to do with albumin.
the
A
systemic
hyperdynamic circulation. Cardiovascular.
spastic vasodilatation.
No, nothing to do with spastic vasodilatation will produce hypovolemia. They have decreased intravascular volume. That is different. But they have an increase in they have hyperdynamic circulation where the low systemic vascular resistance. That is the one which produces hyperdynamic circulation. Why there is a low systemic vascular resistance? The low systemic vascular resistance is because of the increase in the circulatory vasodilatory substances. Because whatever the vasodilatory substances that are produced are usually metabolized in the liver. Now the liver is not working properly. So because of that, a lot of vasodilatory substances like adenosine, nitric oxide, they are all released into the circulation. They are in excess quantity in the circulation. And because of that, there is a systemic vascular resistance will come down drastically. And once the systemic vascular resistance is come down drastically, Mary's law, increase in heart rate, and also myocardial contractility will increase because the afterload has come down. So all these will produce an increase in the volume of the pulse. Pulse pressure will also increase, but there is a decrease in the blood pressures because of systemic vascular resistance is low. So this is one thing is very important. And what is another problem with cardiovascular system? Because of this vasodilatation, everywhere vasodilatation.
Patient is prone to severe cardiomyopathy.
No, that is also there, but vasodilatation is there because of this, vasodilatation of all the vessels. These patients will not respond to your vasopressors and inotropes easily. So that is vasoactive drugs, their effect may be blunted. So because invariably you'll be giving like, norepinephrine, phenylephrine, all these drugs you will have to give many times. So, but their effect may be blunted. So that is another thing you should always remember because of, vasodilatation everywhere. And the other thing you are talking about is these patients may also have cardiomyopathy, isn't it? So this mainly because of the portal hypertension and end-stage liver disease, they can develop cardiomyopathy. And how do you diagnose cardiomyopathy? It is very important to know whether the patient has cardiomyopathy or not, because if a patient has cardiomyopathy, you cannot use routine induction agents like propofol or thiopentone in these patients because they'll collapse immediately if you try to use. So how do you know that the patient has cardiomyopathy?
Increased cardiac output, sir, and
So increased cardiac output is there because of, not because of cardiomyopathy. Cardiomyopathy, there can be a decrease in cardiac output. Increase in cardiac output is because of generalized vasodilatation. Already we discussed hyperdynamic circulation. Whereas cardiomyopathy, if it occurs, what happens to the cardiac output? It will come down. Heart is not functioning properly. There's a cardiomyopathy. Patient may be in failure, isn't it? Cardiomyopathy means invariably the patients will be in failure. And can you, I'll give you a clue. Can echocardiography will help, transthoracic echocardiography?
yes, sir.
How does it help in knowing whether the patient has got cardiomyopathy or not?
So, ejection fraction.
Yeah, ejection, because there will be both systolic and diastolic dysfunction will occur in these patients with cardiomyopathy as a result of chronic liver disease or end-stage liver disease. Both systolic and diastolic dysfunction will occur. So systolic dysfunction you can make out by knowing what is the ejection fraction. So ejection fraction can be less than even 35%. So in those patients where the poor left ventricular functioning, systolic functioning, you have to know, because these patients are, they can collapse on the table. They can have an arrest. And second problem is diastolic dysfunction also they can have. What do you mean by diastolic dysfunction? What is meant by diastolic dysfunction?
Yeah, patients are the coronary perfusion will also be affected.
Nothing to do with coronary perfusion.
The atrium relaxation.
Diastolic dysfunction means, the left ventricle is not relaxing. It should relax normally during the diastole. It should relax so much that, no, what is that extra from some iPhone 3? Who has an iPhone?
No, sir. We just muted it, sir.
Okay.
Yeah.
So, diastolic dysfunction during diastole, the left ventricle has to relax so much so that, the blood from the left atrium to coming into the left ventricle should not have any sort of pressure gradient. It should just because the gravity, it should flow into the left ventricle as soon as the mitral valve opens, isn't it? So if the left ventricle is not relaxing, so that means an increased pressure gradient is required for the left atrium to push blood into the left ventricle. One. Second thing is, because the left ventricle is not relaxing, it cannot hold more amount of blood. So that means the left atrial pressures will increase. So congestive cardiac failure can occur. The back pressure effects. So that is diastolic dysfunction. So these patients with cardiomyopathy as a result of end-stage liver disease can have both systolic and diastolic dysfunction. So you have to subject these patients for echocardiography and try to find out whether they have cardiomyopathy, because it is a serious problem again.
Yes, sir.
Okay, so that is about the involvement of the cardiovascular system. Now coming to the gastrointestinal system. So what are the effects as far as gastrointestinal system are concerned?
The pneumococcal esophageal varices patients might have, sir.
Yeah, very
Because
good. So esophageal varices as a result of back pressure, as a result of portal hypertension. Yesterday we discussed that. So that is
Yes.
one problem. So you have to be extremely careful in using transesophageal echocardiography or anything to be pushed through the esophagus, like even putting a rail tube. Extremely careful, and what you will be doing, suppose if the patient has esophageal varices are there. So if the patient has to be posted for some non-hepatic elective surgery, Would you like to get it, corrected or do something for that? How do you
Yes,
manage if a patient has esophageal varices?
so, they should get surgical interventions, ligation of those.
Before that, you have to put them on. Yesterday we discussed beta blockers,
Yes, sir.
non-selective beta
Yes.
blockers, because once the portal hypertension comes down by splanchnic vasoconstriction, so
Yes.
naturally the varices also will come down because it is as a result of portal hypertension back pressure, isn't it? So you have to reduce the back pressure. So beta blockers, one, then somatostatin or octreotide, isn't it? So that is very important. So another important thing. So these two things, first one can try and see how much reduction in the esophageal varices occur. Otherwise, you may have to go for endoscopic ligation of the varices or injection of sclerosing agents into the before taking up for elective non-hepatic surgery. Otherwise, the chances that because during the surgery itself, the pressures may suddenly increase and they open up and massive hematemesis and hemorrhage can occur and you may lose the patient on the table. That is why this is very important to know as far as the esophageal varices is concerned. And throughout the gastrointestinal system, there can be these variceal problems can occur, isn't it? So dilatation of the vessels because of the back pressure effects. So where else, what else also they can have?
Have splenomegaly, sir.
No, that is okay. But I was talking about the vessels.
Oh, sir, hemorrhoids, sir. We'll have it in
They can
vein.
also have hemorrhoids. And once they
Valley.
open up, because you know that they have coagulopathy also, and the bleeding may not stop, and the patient can even go for severe shock, isn't it? So that is another vascular problem these patients can have. Okay. Then you said that splenomegaly, massive splenomegaly can be there. That's why I asked you yesterday, you should really look for splenomegaly. And many times with the ascites, you may not be able to feel the spleen easily. To feel the spleen, how much the spleen has to increase from its normal size for you to be palpable in parabdomen. Because it is always behind the costal margin, isn't it?
Yes,
So
sir.
if it's just palpable, how much it should have been increased in its size.
More than 4 times. 4 times its normal size.
Why is the normal size? Just for you to just feel it by parabdomen examination, it has to increase twice its normal size. And many times in these patients, the liver may shrink, but massive splenomegaly can be there. So it's very important to examine for the splenomegaly in the exam, especially putting the patient into right lateral position and then feeling for the spleen underneath the left costal margin and asking the patient to take deep breaths. So when the patient takes deep inspiration, the spleen automatically comes down because the diaphragm pushes the spleen down. So then you should be able to palpate if it is just marginally increased in its size. Because splenomegaly is very important. Already we discussed yesterday, any increase in splenic size, the problem is sequestration of the RBCs, sequestration of platelets, and the patient can have thrombocytopenia, anemia, all these problems can be there. Okay, splenomegaly. Then what are the other anesthetic importance as far as the gastrointestinal system and cirrhosis of liver? Other than these already we discussed.
They have increased risk of aspiration.
Yeah, very good. So that is another very important thing. So they should be considered as full stomach. All these patients with end-stage liver disease, especially with ascites, they should be considered as to have full stomach, and you may have to go for rapid sequence induction and integration. So that is one more thing. The next thing is the ascites, as far as the gastrointestinal system is concerned. So what are the problems because of ascites?
Because of ascites, the renal vasoconstriction can occur?
No, that is there. No, physically for the patient.
So it'll be hard for him to breathe, sir, because of
No,
the
the
push
patient
of
may go in
valve.
for distress, isn't it?
Yes, sir.
Patient already will have problems as a result of hepatopulmonary syndrome. He'll have orthodeoxia and platypnea in the sitting position. And if the patient develops massive ascites, so when the patient can have dyspnea or distress, respiratory distress, in lying down or in sitting posture.
Lying down, sir.
Yeah, lying down. So the patients
That
with
will be
massive
pushed.
ascites also can have severe respiratory distress in lying down also. So they may not be able to sit, they may not be able to lie down. They'll have a lot of problems. So what is the cause for ascites as such?
So there'll be decreased the albumin produced by the liver,
One
sir.
is albumin decrease. What are the other causes
Um,
for ascites? There is increased lymphatic production by the liver. Increased amount of lymphatic production by the liver, again, which causes ascites. Next, what is the third common cause? Sodium and water retention by the kidneys.
water retention.
Sodium and water retention. So these are the causes for ascites, and it can be quite refractory sometimes. When do you call it as a refractory ascites?
So more than 5
When
to
do you
6.
call it as refractory? Refractory to what? Because you are going to treat the patient with ascites with diuretics.
Yes, sir. Refractory.
So if the patient becomes refractory to diuretics, you call it as refractory ascites. So maximum amount of diuretics you would be using, maximum dose of the diuretics. So when do you say refractory ascites, depending on the amount of the dosing of these diuretics you use?
Spironolactone 400 mg
400 milligrams of spironolactone, that is a maximum dose, and furosemide,
160 mg, sir, per day.
120 milligram. So more than 120 milligrams of furosemide and more than 400 milligrams of spironolactone, you have used, still the ascites is very high. It's not responding. Then you call it as a refractory ascites. And when do you go for paracentesis? The next, thing you may have to go for paracentesis. So what is the indication for paracentesis?
If patient is in distress, sir.
Yeah, patient is in respiratory distress.
Yes.
Because ascites will produce respiratory distress. It will not allow the diaphragm to come down.
Yes,
Patient will not be able to breathe, isn't it? So then you go for paracentesis. What is usually the maximum volume of the peritoneal fluid that is tapped?
4 to 5 liters in a single sitting,
Yeah,
sir.
not more than 5 liters, isn't it? You don't go beyond 5 liters usually, or tap that much till the patient, respiratory distress comes down. That is your target for doing a paracentesis. So after paracentesis, because the patient would be losing a lot of albumin, should you have to give albumin supplementation?
Yes, sir. We'll have to
You
give,
may
sir.
have to give 25% albumin also, isn't it? So suppose if you want to know whether the ascites is due to portal hypertension or some other cause. So how do you differentiate? Ascites due to portal hypertension or due to some other cause?
SAG ratio we can.
Pardon?
The SAG ratio we can do, sir. Serum albumin is to the ascitic fluid albumin.
Very good, very good. So, you should talk loudly. If you see how loud I am talking, if you are whispering in the exam also, it is very important because the examiner may not hear. Many of the examiners are old and they'll have a decreased acuity of hearing. So you may be correct as far as answering, but they may think that you are not answering at all. So you have to estimate the serum albumin and also the ascitic fluid albumin level. So when do you say it is due to portal hypertension?
When it's, the ascitic fluid albumin is less than less. SAG ratio is more than 1.1, sir.
Yeah, the ratio between serum albumin and ascitic fluid albumin is more than 1.1, then you say it is due to the portal hypertension. So that is what you have to know about. So even after paracentesis, if the patient continues to have refractory ascites, what is the next surgical treatment? It may not be surgical, it may be a percutaneous treatment. Yeah, tips. What is tips? Transjugular intrahepatic
venous shunt.
hepatic photosystemic
Shunt.
and tips, it has to be there, isn't it? Transjugular intrahepatic photosystemic shunt. So it is through the internal jugular vein. So catheters are passed with the needle catheters, and then a connection is made between the portal vein and then the systemic vein, the hepatic vein, and then the portal vein. So that, easily the fluid, the blood can easily pass across and the portal hypertension will come down. In the olden days, they used to do photosystemic shunt, open surgical, photosystemic shunt they used to do. Now with tips, they can do. So what is the problem if they do tips? Is there any complication the patient can develop? Other than hemorrhage and all those things, just don't bother. If properly tips has been done, can it lead to something else?
Bacterial,
For
spontaneous bacterial peritonitis.
that is the ascites. Tips will not produce bacterial peritonitis. If you do tapping, bacterial peritonitis can occur, and sometimes spontaneous bacterial peritonitis can also occur. But if tips is done, what is the patient is prone for a particular complication? What complication? He is prone for encephalopathies.
Hepatic
Encephalopathy. Because what happens is directly the ammonia, instead of passing through the liver, directly will be entering into the systemic circulation and then producing. So the patient will be prone for hepatic encephalopathy. That is one thing which you should always keep in mind. That's why as a last resort tips is done. It is not done in the beginning only. They try all the measures to decrease the ascites. And if everything is, proved futile and still refractory ascites is there, then they probably may go in for tips. Okay, that is about the ascites. Then coming to the hepatorenal syndrome. Can you just discuss about the hepatorenal syndrome these patients are prone for?
Due to the portal hypotension, patient will have increased splanchnic dilatation, and due to ascites, there will be renal vasoconstriction, decreased renal blood hyperperfusion. And
why
because
hyperperfusion? There will be generalized vasodilatation, isn't it?
yes,
Including splanchnic vasodilatation as a result of more circulating vasodilators.
yes.
So because of that, the patient will have hypovolemia. Central blood volume will be very low. Splanchnic blood volume will be very high, but circulating blood volume will be very low. That is how the kidney will respond.
Activation of renin-angiotensin system, sympathetic stimulation, and vasopressin system gets activated, which leads to renal vasoconstriction.
So very good. So, but why renal vasodilatation will not occur? Renal artery dilatation. Generalized vasodilatation is there, isn't it?
To compensate for it, the RAS will get activated and it will cause vasoconstriction.
Yeah.
That's why
The renal vessels will not respond for these generalized vasodilators. So circulating vasodilators. Usually, as you said, that renin-angiotensin-aldosterone system will take effect, and there is any decrease in the renal perfusion as a result of hypovolemia, renal vasoconstriction will occur. And this is because of that. What kind of renal failure is hepatorenal syndrome? Is it pre-renal, renal, or post-renal?
pre-renal.
Yeah, it is always pre-renal. What do you mean by pre-renal?
Because of the decreased blood supply to the
Kidney. So Is kidneys normal or abnormal in these
Kidney is
patients?
normal, sir.
Yeah,
But
kidneys are
absolutely.
normal because what they have found is when these patients die, their kidneys are transplanted to other people who require, renal transplantation. These kidneys have worked normally, functioned normally. That means that shows that it is mainly because of the hypoperfusion to the kidneys. The patients have developed, the prerenal syndrome. And how do you differentiate prerenal renal failure and renal failure, or because of the acute tubular necrosis? How do you differentiate? Because the management will be entirely different.
RFT levels, response to diuretics, serum creatinine level, we can assess.
No, serum creatinine will rise. In all prerenal failures or renal failure, whatever may be the cause, renal renal parameters like blood urea, serum creatinine will increase. So what you have to do is urine estimation of sodium, urine osmolarity, fractional excretion of sodium. These three tests are usually done to differentiate prerenal with renal or acute tubular necrosis. What happens to the sodium excretion? Urinary sodium excretion in prerenal and acute tubular necrosis.
There is sodium retention happens in a pre.
Very good. Very good. So quantity of sodium excreted in the urine will come down, isn't it? So it's usually less than 10 milliequivalents in prerenal problem. And if it is an acute tubular necrosis, because it cannot hold on to the sodium whenever there is acute tubular necrosis, the kidney itself is not functioning properly. So usually it will be more than 20 milliequivalents per liter, the urinary sodium. What happens to the osmolarity of urine?
Is increased osmolarity
In
in pre.
no, where the concentrating ability of the kidney is maintained, prerenal or acute tubular necrosis.
Okay. So
Concentrating ability, dilution ability of the kidney is maintained in
pre-renal it is maintained.
yeah, prerenal. It is because the kidneys are functioning normally. One of the functions of kidneys is concentrating ability of the kidney of the urine, isn't it? So because whenever the blood flow is low, it will try to retain sodium and also try to retain water. That is why, the urine osmolarity will increase because it is a concentrated urine now. So the urine osmolarity will be more than 400 milliosmoles per liter in pre-renal. In case of renal, it will be less than 300 milliosmoles because the concentrating ability is lost. There will be more amount of water will be lost through the kidney in acute tubular necrosis. So urine gets diluted. That is why the urine osmolarity will be on the lower side. So what happens to the fractional excretion of sodium in
It will
case?
be low
Yeah.
in case pre-renal.
How much low means what? How much?
Less than 1%.
Yeah, very good. So it is less than 1 in pre-renal. It will be more than 1 in case of the acute tubular
Yes.
necrosis. Very good. Very good. So, and how many types of hepatorenal syndromes are there? Yesterday we were answering something.
Two
When
types
I
are there.
was asking about hepatopulmonary or something, you were, no, halogen hepatitis, you were getting confused with hepatorenal syndrome. So now I think yesterday you went and then read about hepatorenal syndrome and halogen hepatitis.
Yes.
Okay. So what are the types of hepatorenal syndrome?
Two types of hepatorenal syndrome are there, sir. The first one is the
Okay.
rapid progressive type. The second one is the indolent type. The first one occurs usually within 2 weeks. The second one can take up to even 6 months of progression of the renal failure. Then the
Yeah.
first one type is associated with severe renal impairment. And then the second type is moderate renal impairment. Then
So
serum
which one
creatinine
respond to your, terlipressin, albumin
type 1.
treatment? Which one will respond?
Type 2 will be responding.
Type 2 will respond. Type 1
Type
may not respond.
2.
What is the Now, type 1, the mortality is very high.
Yes,
And, for type 1 hepatorenal syndrome, what is the management, treatment?
Albumin infusion for
That is for type 2, usually you do. Even type 1, you can try. But even liver transplant,
liver
only
transplant.
used to go for liver transplantation, type 1,
Yes.
because rapidly progressive. So mortality is very high. That is about the hepatorenal syndrome. Now, coming to the other, the pathophysiology is the brain, the hepatic encephalopathy. So, what is this hepatic encephalopathy? What is the cause for hepatic encephalopathy? How do you classify the stages of hepatic encephalopathy? How do you manage?
The end product of nitrogen cycle is ammonia, which needs to be excreted via which needs to be metabolized and excreted as urea, which happens in the liver.
So, where
Conversion
exactly? No, the ammonia which is produced, where ammonia is produced?
nitrogen cycle end product, sir.
In the intestines, isn't it? Majority
Yes,
of
sir.
them. Because of the breakdown of protein, whatever we ingested protein is broken down by these bacteria in the intestines, and they release ammonia. Ammonia gets into the circulation and it comes to the liver, and in the liver it gets converted to urea,
Urea.
isn't it? And in which particular, there are 3 zones in the hepatic lobe: zone 1, zone 2, and zone 3. Which particular zone the conversion of ammonia to urea occur?
3, sir.
Zone 3 or zone 1?
Zone 1. Zone 1.
Zone 1. It is aerobic metabolism. It is in zone 1, because zone 3, majority the anaerobic metabolism, especially the metabolism of the drugs, will be occurring. So it occurs in zone 1. So here, because the liver is failing, so ammonia is not getting converted to urea, and more amount of ammonia will enter into the circulation. And what does ammonia do for these astrocytes?
It gets accumulated. Astrocytes are present in the blood-brain barrier. It gets accumulated, which causes indrawing of all the water into the
So
cell.
does it get converted to anything, any other chemical inside the body?
Gets converted to
Huh?
glutamine, sir.
Yeah, gets converted to glutamine. That is very
Glutamine
important. Glutamine gets accumulated in the astrocytes, and what it does,
it
it
causes
draws
water indrawing into the astrocytes, sir, and causes cerebral
there will
edema.
be swelling and produces cerebral edema, isn't it? So all the effects of the hepatic encephalopathy is because of this cerebral edema that occurs, isn't it? So what are the different stages of hepatic encephalopathy?
Uh, Best Haven criteria for hepatic encephalopathy grades. There are 4 grades.
Okay.
First one is lack of awareness of the patient with mild disorientation. Then there is sleep disturbance also present.
Hardly you will be knowing whether the patient is going in for hepatic
Yes.
encephalopathy. Stage 1 is, unless you are keenly observing the patient, then only you may be able to see some changes in his behavior. Otherwise, you may not be able to make out. What about the asterixis?
Uh, in the first one, it is not present, sir.
They are not usually not there.
Yes,
Okay.
sir.
And then what about stage 2?
In stage 2, patient will be lethargic and they'll have mild disorientation, sir. And they'll have inappropriate behavior, sir. Drowsiness will drowsiness will.
And a lot of disorientation can be there.
Yes,
Stage
sir.
2 is can make out. What about the asterixis? Yeah. Tapping tremors, and also EEG changes can be there. Spikes can be there, isn't it? So how do you check for asterixis? Because yesterday I don't know whether you mentioned about asterixis in your examination.
In science of liver cell failure, we mentioned, sir.
You mentioned. So how do you check for flapping tremors? What you do?
We have to make the patient have outstretched arms, sir, in front, and they have to.
Your hand is not seen.
So like
Okay.
this, sir. And then you have to tell them to hold the hand in this
So
position.
you have to press it. You have to apply counter pressure
Yes, sir.
like this. Once you apply counter pressure and leave it. So continuously,
Yes,
it
sir.
starts flapping like the wings of a bird, isn't
Yes,
it?
sir.
So this asterixis or flapping tremors usually starts in the second stage of hepatic encephalopathy. Okay, third stage.
Patient will have marked confusion, sir, and they'll have incoherent speech. Patient will be arousable to stimuli, then
He may be in almost, unconscious state,
yes,
but he can be,
conscious.
aroused by deep painful stimuli.
Yes, sir.
And EEG is still triphasic EEG can still be there.
Yes, sir.
Triphasic EEG with asterixis being present.
Yes.
Stage 3 also. What about stage 4?
Patient coma, unresponsive to stimuli, unarousable. Patient will
Yeah.
have decelerated posturing.
Yeah. And EEG may be flat almost nearly. The triphasic EEG will not be there. And asterixis will be absent,
Yes, sir.
isn't it? So why should you know whether the patient, why should you examine for these hepatic encephalopathy? What is its anesthetic importance?
Um, um, Drugs which you are giving are not exaggerate.
They're extremely sensitive to your sedatives and hypnotics.
Yes, sir.
And, they may not come out of anesthesia many times, especially stage 3 or stage 4. They may not come out of anesthesia. And delayed recovery is very common with stage 1 or 2. Stage 3 and 4, they may not come out. So it is very important to rule out hepatic encephalopathy before, accepting the patient. So if the patient has hepatic encephalopathy, you have to treat. How do you treat? How do you manage?
The first treatment of the precipitating factors,
Okay.
like constipation, any gastrointestinal
What is
bleeding,
the precipitating factor? Most common precipitating factor?
constipation, gastrointestinal
Infection,
deficit,
constipation, storage, high
yes,
protein diet, isn't it?
hypokalemia, hypoxia, yes, sir.
Yeah,
Hypoglycemia.
all these hypoxia, hypercarbia, all these can be precipitating factors. So try to know what is the precipitating factor. Try to minimize these precipitating factors. Okay, then next.
If the patient is in grade 3 or grade 4, we can give octreotide infusion for the patient.
What infusion?
Octreotide, sir.
Octreotide, okay, may not help much. But what is more important is, the intestinal bacteria which are producing the ammonia, you have to reduce them, isn't it?
Yes,
So
sir.
because production of ammonia itself, you have to take care. So you give decreased protein intake for the patient, give protein, less protein in the diet, one. Second thing is, anything lactulose. Have you heard about lactulose?
Yeah, that's for constipation, we have to mix it.
Yeah, you can start giving through the Ryle's tube
Yes, sir.
lactulose. And how lactulose will help?
Uh, it'll promote a gastric, intestinal emptying, sir. So, due to constipation.
Lactulose produces an acid media in the intestines. So because of that, because it releases lactose and acetic acid. Because of acetic acid, so there is more of the pH will drop. So in that acid pH or acid media environment, the bacteria may not grow. So the bacterial growth will come down. So that's how lactulose will act. And anything else you will give, any antibiotic you will be giving?
Neomycin,
Yeah, neomycin or nowadays, any other mycin?
rifaximin.
Yeah, rifaximin. It is also rifamycin group of drug. So that again, kills majority of these bacteria so that the production of ammonia can come down. So if the patient is on neomycin or rifamycin, do you have any anesthetic importance?
Neuromuscular blocking agent dosage
Very good.
requirement is reduced.
No, why? How they are related? what sort of a drugs are these? What sort of drugs are these? Rifaximin and neomycin. They're aminoglycosides,
Yes, yes, sir.
isn't it? Like streptomycin, your amikacin, gentamicin. So they are aminoglycosides. So how aminoglycosides, if the patients are on, how they interfere with your neuromuscular drugs. So because they block the fast calcium channels at the neuromuscular nerve ending, isn't it? Skeletal muscle motor nerve ending. They block the entry of calcium by blocking the fast calcium channels, the T channels. You have L channels and T channels. They block the T channels. So the calcium entry is very important for release of acetylcholine. So now the calcium channels are blocked means acetylcholine will not be released. All are non-depolarizing muscle relaxants. They're actually competitive antagonists of acetylcholine, isn't it? So since acetylcholine levels will come down at the neuromuscular junction, so naturally they'll have a prolonged duration of action. So though we know that neomycin and these rifaximin may not get absorbed into the circulation much, but some amount may be absorbed and they may have this effect on the neuromuscular blocking agent. So it is very important to continuously have a neuromuscular junction monitoring when patients are on these drugs. So these are the things which you have to do for the patients with any drug is given for hepatic encephalopathy to reduce.
L-ornithine and aspartate to increase the ammonia clearance.
That is if the liver is functioning properly.
Mm.
That only helps in conversion of ammonia to urea. But the liver is not functioning properly, isn't it? Flumazenil is one of the drugs that has been tried. What is flumazenil? Heard about flumazenil?
Yes, sir. It's an antidote. Yes, sir.
Antidote for? It's a benzodiazepine antagonist. Flumazenil is a benzodiazepine antagonist. So that has been tried. And these patients are extremely sensitive for benzodiazepines.
Yes, sir.
So that's how, any GABA mimetic agents. That's how flumazenil has helped in some of the patients. So because I told you that they are so sensitive to these hypnotics and sedatives, they may not come out of anesthesia also. So you have to be careful. So that is about the hepatic encephalopathy. I think we have discussed most of the effects of end-stage liver disease. Okay, now your patient is being posted for hernia surgery. Now, what all the investigations you would like to do for this patient?
Starting with complete blood count, check for the hemoglobin level, platelet level, because the patients are most known to have thrombocytopenia. Then sugar monitoring.
Thrombocytopenia is very common, isn't it? Because of already we discussed, because of the enlarged spleen and also thrombopoietin secretion not there from the liver, which is very important in production of thrombocytes. So platelet count may be on the lower side. So you have to get a platelet count. Okay. Then
electrolytes we'll have to see, sir.
Pardon?
Electrolytes we'll have to see, sir.
Okay, electrolytes. Especially if these majority of these patients can be on diuretics. But of course, your patient, you do not know whether he is on diuretic or not. So because he has got so much of ascites, so he may be, once he is admitted, he may be put on diuretics, definitely. So electrolytes. And if he is on spironolactone, there can be, yesterday we discussed, there can be hyperkalemia. And if he is on furosemide loop diuretic, he can also have hypokalemia. Okay. Okay. So electrolytes you have to study. Then
sugar monitoring, they're more prone for hypoglycemic episodes because of
okay, very good. So you have to get a fasting blood sugar, postprandial blood sugar. right?
Renal function parameters to check if
How
hypertension
about urine? Urine, you did not tell anything about urine.
urine routine.
Because already we discussed, isn't it? Urinary sodium
Urine
and
sodium.
urinary osmolarity, fractional excretion of sodium,
Yes,
and urine for the other important things like, the quantity of urine itself per day, because there may be oliguria also. A patient may be going in for renal failure, pre-renal failure, isn't it? So that is very important. Plus, as you are suggesting, serum creatinine and blood urea. And you have to do serial estimation of serum creatinine, because
yes.
suddenly the patient may go in for type 1 hepatorenal syndrome. Okay. Then,
Liver function test.
yeah, liver function tests. That before that, you always classify whenever you are asked about investigation, you always say general investigations and specific investigation.
Yes.
So specific investigations will be liver function tests that you can tell afterwards. Before that, you tell about the general investigations. For a 60-year-old man, what all the other investigations you would have done?
Blood grouping and typing will have to do.
Yeah, blood grouping and cross matching also, because they may bleed like anything, isn't it?
Yes.
So they may have coagulopathy. For that, we'll have to come to specific investigations. And ECG, you don't want to do?
Yes, ECG.
Yeah, what the problem you can expect in ECG?
Increased QT prolongation can happen.
Yeah, QTC interval can be there, prolonged QTC interval in any patient with cardiomyopathy or even with hyperdynamic circulation. There can be prolonged QTC. Why should you worry about prolonged QTC? What problem can occur if there is prolonged QTC? Patients are prone for a particular type of dysrhythmia. What type of dysrhythmia? Torsades de pointes.
Yes, sir.
Polymorphic ventricular tachycardia. It can be fatal also. And especially when you are using drugs which further prolong the QTC interval, like your sevoflurane can prolong QTC interval. Already patient has got a prolonged QTC interval. If you are using sevoflurane, patient can go in for torsades de pointes. Your ondansetron can produce butyrophenones like droperidol, haloperidol. All these can produce, further prolongation of the QTC interval. And there is hypocalcemia. If it occurs, if you hyperventilate, produce hypocalcemia, that especially alkalosis, if you produce respiratory alkalosis, again, the patient can develop torsades de pointes. So that is why in ECG is very important. And another important thing about ECG is these patients may also have a 60-year-old man can have a coronary artery disease also. And because he is not moving much, because he is having so much of tiredness because of the end-stage liver disease, he may not be presenting you with angina. That is why you said that there is no history of angina, isn't it? The patient may still have coronary artery disease. So ECG, if he has a coronary artery disease, ECG may show, especially the ST depressions, T wave inversions can be there, isn't it? ST wave changes. So that is why an ECG is very important. Okay, what other investigations?
X-ray, any pleural effusion.
Yeah, X-ray chest is important to rule out any pleural effusions, right?
Echocardiography.
Transthoracic echocardiography. Again, we just discussed that the patient may have cardiomyopathy. One. Second thing is portopulmonary hypertension. It can be only diagnosed with using your transthoracic echocardiogram. What is the MPAP? What is the mean pulmonary arterial pressures? You can make out. And you know that if it is high, you know that your patient will have an increased morbidity and mortality after surgery or intraoperatively. That is why an echocardiography. If the patient has coronary artery disease and the ECG is not very clear about the diagnosis of coronary artery disease, what else by using an echocardiography can you do something else? Because stress ECG, he you cannot do because this patient will not be able to do any exercise. What echo you have to do?
Esophageal echo.
No, dog vitamin stress echo, isn't it?
Yeah.
You stress the myocardium to know whether the patient has got any coronary artery disease. So dog vitamin stress echo you may have to do to know whether the patient also has coronary artery disease. Because if the patient also has coronary artery disease, then your problems will increase in the management. Okay, so that is about echocardiography. So what other investigations?
Specific investigations.
Yeah, specific investigations now. Okay. Now, what specific investigations as far as end-stage liver disease? How do you classify these investigations? Or liver function tests, isn't it? How do you classify the liver function tests? One is to test for hepatocellular integrity.
Yes, sir.
Test for hepatocellular integrity. Second is test for, cholestasis.
Yes, sir.
The obstructive cholestasis or obstructive, the biliary obstruction is there. So for that, it is called as test for cholestasis. Third is test for synthetic functions of the liver.
Yes, sir.
And fourth is test for excretory functions of the liver. So these are the four tests usually you may have to do for liver function. So what are the tests that are done for hepatocellular integrity?
Hepatic enzymes, sir. AST, ALT.
Hepatic enzymes, yes, very good. So what are these hepatic enzymes? Usually for cellular integrity, you will be doing
ALT and AST, sir.
AST and ALT, isn't it? Alanine aminotransferase, aspartate aminotransferase. And, and LDH also, lactic dehydrogenase.
Yes,
And
yes, sir.
glutathione S transferase. So these 3 or 4 for hepatocyte integrity, hepatocellular integrity, because they are present inside the hepatocytes. Whenever there is a damage to the hepatocytes, they'll come out.
Yes.
That means they show the integrity of the hepatocytes, isn't it? So in liver damage, so definitely the liver is made of mainly these hepatocytes. And liver damage means damage to these hepatocytes. And there can be increase in the levels of these enzymes. So these, AST, ALTs. Okay, so what is the normal AST and ALT, upper normal limits?
25 to 50 units per liter.
Usually up to 35 international units per liter, isn't it? So up to 35 international units, 0 to 35, we always say. And why they are 35? Because there will be some amount of, cellular death will be occurring, programmed cellular death or apoptosis, what we call. Aging hepatocytes, they'll be, dying and they'll be releasing these AST, ALT into the circulation. That is why normally you have about up to 35 international units of AST and ALT. So whenever there is hepatocellular damage, they'll increase. So how do you classify based on the amount of AST, ALT? Mild, moderate, and severe damage.
So, mild will be in hepatocellular.
No. How do you classify mild, moderate, and severe based on the levels of AST and ALT?
More than 5 times elevation is severe.
No, when AST, ALT is between 100 to 250, you call it as mild. When it is 250 to 1000, you call it as moderately severe. And severe damage is when the AST, ALT is increased to more than 1000 international units per liter. Okay, so up to 100 to 250 and 250 to 1000, more than 1000. Now, another very important thing here is the AST-ALT ratio.
Yes, sir.
Yes. So why AST-ALT ratio is important?
to it's to rule out the causes of
Very
the
good.
disease.
What
So
happens in alcoholic hepatitis or alcoholic liver disease?
alcoholic liver disease will be increased some more than AST is to ALT ratios 2 is to 1:1.
To ALT will be more than 2.
Yes, yes, sir.
AST will be increased twice the ALT,
Yes,
isn't it?
that's
And why this occurs? Why AST will increase more than the ALT?
so,
Where is AST present? Where is ALT present in the hepatocytes?
actually AST will be
No, because when the ratio is like that, you have to know why, isn't it? Now, because the AST is present both in the mitochondria and the cytoplasm of the hepatocytes. Alcohol damages both cytoplasm as well as the mitochondria. That is why the AST levels will be much higher than the ALT. ALT will be present only in the cytoplasm, not in the mitochondria, because infections will not damage the mitochondria. They'll only damage the cytoplasm, so that only the ALT levels will increase more than the AST in case of other infections like viral hepatitis and all. That is why AST-ALT ratio will be much less than 1 in viral hepatitis or other causes of liver damage. Whereas with alcoholic liver damage, it is AST-ALT ratio will be more than 2 because the mitochondrial damage. And again, in Wilson's disease, what happens to AST-ALT ratio? It will be more than 4. It will be more than 4. And whereas in steatohepatitis or fatty liver disease, what happens to AST-ALT ratio?
will be less than 1, sir.
Yeah, less than 1. That's how you differentiate alcoholic hepatitis and fatty liver disease. If it is due to alcoholic hepatitis, the ratio will be more than 2. And if it is due to fatty liver disease, it will be less than 1. That's how you can differentiate cirrhosis as a result of fatty liver disease, steatohepatitis, or alcoholic steatohepatitis. Okay, so that is the importance of AST-ALT. So that is about the integrity of the hepatocytes. That is one of the functions you have to do. Second, I said is about the cholestasis. So what are the enzymes you study for cholestasis?
ALP and gamma GGT, sir. Gamma glutamyl.
Gamma glutamyl transpeptidase or transferase, and ALP is alkaline phosphatase, and 5' nucleotidase.
Yes.
3, isn't it? So why they'll increase in cholestasis? Because they are normally secreted into the bile. Alkaline phosphatase, gamma glutamyl transpeptidase, and 5' nucleotidase, they are normally secreted into the bile. So if there is obstruction to the bile, entry into the intestines, now what will happen is these will enter into the circulation and they'll increase. That's how you can diagnose cholestasis or the liver disease as a result of or biliary disease, because the liver diseases are classified as basic liver disease and biliary diseases, isn't it? So biliary diseases you can know by getting these enzymes studies done, isn't it? So alkaline phosphatase, and alkaline phosphatase can also increase because of other than the cholestasis, isn't it? So what other cause can increase alkaline phosphatase? Any bony diseases like Paget's disease or even secondaries in the bone, especially the patient having carcinoma prostate, invariably the metastasis will be in the bone. Then also alkaline phosphatase will increase. It is not specific to the cholestasis. So that is the reason you have to do the alkaline phosphatase and GGT and 5-nucleotidase. If
Mm.
all three are increased, then you know that it is because of the cholestasis problem. If only alkaline phosphatase is increased, gamma glutamyl transpeptidase and 5-nucleotidase have not increased, then it may be causes due to something else, maybe bony disorders, not due to cholestasis. So that is very important for us to know about. And
Yes.
another very important thing is the ratio between the ALP and ALT. Is it important? Alkaline phosphatase to or ALT to alkaline, any of these things. So suppose you have a ratio between alkaline phosphatase to ALT. When will be the ratio will be high? In which conditions? Just now we discussed in conditions where there is biliary disease.
Yes.
Cholestasis is there, where alkaline phosphatase will be very high, and ALT may be normal because there is no problem with the liver, isn't it? So the ratio can be very high, including it may be more than 5. So suppose if it is basically because of the liver disorder and not due to the cholestasis, if there is a some amount of intrahepatic cholestasis is there, then still the ALT ratio will not be more than 2. Lot more than 2. That's how you can differentiate. That's how doing just enzyme studies is not important. You have to know the application of that, isn't it? So okay, now these are the things about the cholestasis functions of the kidney you are testing. Then synthetic functions. What is the synthetic function which we usually do?
Coagulation profile, albumin synthesis.
Yeah, both albumin and coagulation profile. Very good. So albumin levels you have to do, get it done. And invariably albumin level will be low in patients with liver disorder. If it is due to cholestasis, the disorder is a cholestatic problem, then albumin level may be normal. Okay. So albumin level 1. And if the albumin levels are very low, you may have to even transfuse albumin before the patient for surgery, isn't it? Okay. Now about the coagulation factors. So yesterday we discussed about the procoagulants getting converted to coagulation factors by vitamin K. So that is a problem in patients with cholestatic diseases where vitamin K is not absorbed, and you in such situations you give vitamin K, the coagulopathy will become normalized. Whereas in these patients with liver disorders, so the coagulation factors themselves are not synthesized. That is a synthetic function. And what all the, again, one more yesterday's revision, what all the coagulation factors which are synthesized by the liver?
Vitamin K dependence. So, except
All coagulation factors except
3, 8, 1 milligram factor,
3,
and
4, 8, and 1 milligram. 3, 4, 8, and 1 milligram factor. So these 4 are not synthesized by the liver. All other coagulation factors are synthesized by the liver. So because they are not being synthesized, the patient's INR will be prolonged. And prothrombin time also will be prolonged. So INR will be high. So what is the difference between prothrombin time and INR?
INR is internationalized normalized ratio comparing the test subject with that of the control value, which among the general
With the
population.
standard control value. Prothrombin time is just a prothrombin time, isn't it? So it will be always in seconds. Whereas INR is always, it is say 1, 1.5, 0.5 like that, isn't it? So that is the difference between that. So you have to get it done because, invariably these patients may have coagulopathy. And if it is due to liver problem, end-stage liver disease, will it respond to your vitamin K? It will not respond to your vitamin K, isn't it? If it is due to cholestasis, then only it will respond to vitamin K. So how do you manage if the patient has prolonged prothrombin time or INR is raised?
Electrolyte transfusion, fresh frozen plasma and cryoprecipitate transfusion can be done.
Yeah, you may have to go for a fresh frozen plasma, cryoprecipitate, or prothrombin complex concentrate with 7 added, isn't
Yes.
it? So these are, suppose if you think that a patient has got cardiomyopathy, I don't think you'll be going in for fresh frozen plasma, because how much of fresh frozen plasma you may have to give, for getting the coagulopathy treated. What is the dose of fresh frozen plasma? Usually you may have to go for 15 ml per kg body weight.
Okay, sir.
15 ml per kg body weight of fresh frozen plasma. In a 70 kg patients, it can be 1 liter.
Yes, sir.
And
Yes.
giving 1 liter of fresh frozen plasma in a patient with cardiomyopathy, he will go for circulatory overload.
Mm.
So in such situations, ideal would be to go for, if available, prothrombin complex concentrate. PCC, it is called as. So that is ideal in such patients. Okay, so that is another very important thing. And in order to know exactly what is required, whether fresh frozen plasma is required or platelets are required, what is actually required, what other tests you may have to subject these patients with.
Thromboelastography, sir.
Yeah, viscoelastic tests you may have to do, isn't it? So thromboelastography or ROTEM, rotational thromboelastography, you may have to subject. So this also, the other investigations you may have to do. Okay. So then is excretory functions, which usually you will be doing for excretory function, which is excreted through by the liver through the biliary system. Bilirubin. Bilirubin, isn't it? So yesterday we have discussed in detail about the bilirubin. Invariably, the bilirubin will rise. Whenever cholestasis is there, then also it will rise. Whenever there is increased production of bilirubin because of increased damage to the RBCs, then also it will rise. Whenever liver disease is there, then also it will rise, isn't it? So already we discussed how you can differentiate. So prehepatic, hepatic, and posthepatic problems, jaundice, isn't it?
Yes.
So bilirubin will be raised. So that is whether the unconjugated bilirubin is raised or conjugated bilirubin is raised. Unconjugated bilirubin will be raised in prehepatic causes, hemolytic anemias. And conjugated bilirubin will rise in patients with cholestasis, isn't it? So both may be increased in liver disorders. Both conjugated and unconjugated bilirubins can increase. So these are the liver functions you may have to subject the patient for. And any other investigations the patients are usually subjected to?
Urine bilirubin, serum ammonia.
Yeah, that you have already told about urine estimation of, okay, urine bilirubin. What sort of urine bilirubin will be there? Is it conjugated or unconjugated?
Conjugated, sir.
It has to be conjugated, isn't it, to come into the urine. That is what is a bile pigment, urobilinogen and the bilirubin. Yeah, that is usually, it can be there it may not be there in cholestasis. It will be there in cholestasis, especially bilirubin will be there. Urobilinogen will be absent in the urine, isn't it? Bilirubin is conjugated bilirubin. It will be there in the urine, but urobilinogen, because bile has to enter into the intestines to get converted to urobilinogen and stercobilinogen. Okay, so any other investigation?
Serology will have to do for the patient, sir.
Pardon?
Serology we'll have to do for the patient, sir.
Okay, that is to rule out any cause of liver damage, because HbA was, your hepatitis B or hepatitis C. Okay, that is another very important. Okay, then.
Ultrasound abdomen we have to do, sir.
Yeah, ultrasound, very important. Ultrasound to know the splenomegaly, because you're not able to find out the spleen. So you can find out the spleen. And anything else, the ultrasound, especially to know whether cirrhosis is there or not?
Yes, the liver architecture. See.
Architecture 1, anything regarding the liver? So liver elastography is one more method using ultrasound. Liver elastography can be done, and if it is more than 20 kilopascals, you are using elasticity of the liver, then you say that it is cirrhosis of liver in order to diagnose. Okay, so ultrasound abdomen is important. Application of ultrasound again is elastography of the liver. Okay, so these are some of the liver biopsy also can be done to know exactly what is the cause. Sometimes it may have to be undertaken, and the patient may have to be subjected for CT scans, and especially if you are suspecting malignancies. So MRI, CT scans, all these things. Okay, now everything is over. You have investigated the patient. Now, how do you optimize the condition of the patient before taking up for surgery? How do you optimize?
Nutritional, we'll have to see, sir.
Now, what are the methods of optimizing the patient?
First, you have to optimize for the nutritional status,
Yeah,
cardiopulmonary function.
nutritional status, albumin levels have to be improved. Okay. And these patients, are they prone for infections?
Yes, sir. Antibiotic coverage.
Why
Antibiotic coverage.
they are prone for infections?
So due to cirrhosis, they are more prone for spontaneous bacterial peritonitis. So
No, that is different. Other than spontaneous bacterial peritonitis, any other routine infections are also they are prone for.
routine is
Because what is the function? One function of the liver? Immunosuppression.
yes,
Immunosuppression.
Sorry, immunity, not immunosuppression. It produces immunity. It is very much involved in the immunity of the body, isn't it? So these patients can be immunosuppressed whenever they have cirrhosis. So they require antibiotic coverage. So you may have to put them on antibiotics. Okay. Then
Medical management of ascites before taking up the patient for surgery.
okay.
We
Okay.
have to collect the dyselectrolytemia the patient has.
Very good. Very good.
coagulopathy also.
Deranged
coagulopathy also will have
Yeah,
to.
it has to be treated, isn't it? So before picking up, so just now we discussed about vitamin K may not help, and you may have to go for giving, fresh frozen plasma or PCC. That is always there. Okay, so you have to optimize the condition of the patient as far as possible before taking up the patient for surgery. Okay, now you have optimized the patient's condition. Now he has been posted for, we'll discuss two things. One is the patient is being posted for, hernia repair, and his coagulation profile has been optimized.
Yes.
And another, the same patient, you have tried and you have not been completely optimized the coagulation profile, but the patient requires surgery. And how are you going to, what is the anesthetic management of that particular patient? Now, first is patient's coagulopathy has been managed. So now we have done all the coagulation profile. Coagulation profile is normal. So what is the technique you will be using for anesthetic technique?
We can do regional anesthesia for the patient.
Don't say regional anesthesia because it's a broad thing. You have to be very specific. Suppose you are managing this case, the patient will be inside the OT, and what anesthetic technique you would be using. You will not be telling, oh, I'll use regional technique, isn't it? You have to be very specific what technique you want to use.
Subarachnoid block.
Pardon?
Spinal anesthesia. Subarachnoid block can be.
Spinal anesthesia. Okay. So any particular type of spinal anesthesia? Because you want to, do not want, because these patients can have a lot of hemodynamic
Yes.
perturbations can occur if you give spinal anesthesia regularly and then it ascends high up. So patients can have severe hypotension and it can be refractory hypotension also.
Segmental.
Segmental spinal for hernia. Segmental spinal is, you will be going up. Segmental spinal is in the thoracic level.
So, load of spinal can be.
Load of spinal means what? You are specific thing when you are using a low dose. Have you heard about selective spinal anesthesia? You can try selective spinal anesthesia. What is this selective spinal anesthesia? Where is your, the patient is having which side hernia?
Right side.
Right side. Now, how do you go ahead for selective spinal?
We have to make the patient lie in the right lateral position. We can give anesthesia.
And low dose. You don't
Yes.
give high dose. You give just about 1.5 to 1.8 ml of bupivacaine heavy. You will have to use. Keep the patient in lateral position for at least about 10 minutes after giving. And while giving also, you have to use a pencil point needle instead of a Quincke needle, because pencil point needle will produce less turbulence inside the CSF, so that your whatever the drug you are giving will settle down in the dependent part of the CSF, and you'll have to inject very slowly so that you are not creating any turbulence. You may have to take about 1 minute or 1.5 minutes to inject this 1.5 to 1.8 ml, and keep the patient in flex position only for about 5 to 10 minutes. That produces more selective blockade, so that in the non-dependent posture, the less number of spinal segments will be blocked, and so overall sympathetic blockade will be much less. So the hemodynamic changes will be much less. Fall of blood pressure, bradycardia will be much less. So selective spinal is one of the technique you can use. What about graded epidural?
Yes.
Can you go for graded epidural?
Yes, sir.
Now, any problem with graded epidural in these patients? What is the quantity of local anesthetics you have to use for graded epidural? Is same as like selective spinal or much higher?
So large volume of.
Yeah, you have to use 15 to 20 ml when you are using graded epidural, for that matter, even if it is a graded epidural. So what is the problem in patients with end-stage liver disease and local anesthetics?
You normally try reducing the local anesthetic dose to less than 20 to 30% less.
No, it is not a question of 20 to 30% less, because all these amide local anesthetics, they have to be metabolized in the liver. And liver is failing in its functioning. So naturally, all these amide local anesthetics, they'll not get metabolized. So local anesthetic systemic toxicity can be very high. Patients can go in for local anesthetic systemic toxicity. So you have to be careful in how much of local anesthetic you'll be using. That is why you have to be extremely careful in using even tab block.
Yes, sir.
Yes.
Because even in tab block, you may have to use 15 to 20 ml of local anesthetics, isn't it? You may say that, okay, I'll give tab block for post-op analgesia. No, you have to be extremely careful. So even for, field block, inguinal field block is also one of the things you can try. But again, there is always a risk of local anesthetic systemic toxicity when you are using amide local anesthetics, isn't it? So these are all the problems you can experience. That's how, the most safe technique can be a selective spinal. So invariably in the exam, you may have to tell like that.
Yes, sir.
Okay, suppose the patient has coagulopathy or he has been posted for an emergency hernia reduction because he has developed an obstruction and now he has been brought as an emergency. Many times even though there is no obstruction, your surgeons will bring it as an obstruction, isn't it? Many times. Some of them, not everybody. So anyway, now there is a definite obstruction is there. So it's been brought as an emergency. end-stage liver disease. You have done an INR is more than 2. Now platelets are also less in number. It is less than 50,000. Now how do you proceed? What kind of, how are you going to manage this kind of a case?
General anesthesia we would prefer with when
You will be,
hemodynamic obstruction.
you will be going in for GA, of course, but you have to prepare the patient. You can't
Yes,
just go for the general anesthesia when INR is 2. The patient is going to bleed to death when they are doing a laparotomy for this patient for obstruction of the hernia. So you have to at least optimize. Just now we were discussing
Yes,
what
sir.
is okay.
FFP and PCC
Yeah, you
trans.
have to go for either FFP or PCC. You have to go. Then platelets. What about platelets?
So platelet transfusion.
Yeah,
So we
what
have
platelets? Whether random donor platelets or single donor platelet.
Single donor platelets.
Single donor platelet will increase the platelet level by how much?
uh, 3,000. So
Single donor will increase by 35 to 40,000 because you people are murmuring your answers. You are not coming out with not able to hear at all. So you may be telling proper thing, but I am not able to hear you. You are just murmuring to yourself. So if you want to answer, you should answer properly. Then only so that I can hear, and then that is why everything I am telling. So random donor will increase by 5 to 8,000 platelets, whereas single donor will platelet SDP will increase by 30 to 40,000. So that will increase the platelet level to more than 50,000. But now you have given FFP, you have given platelets. Can you go for regional anesthesia?
No.
No, sir.
Again, it's contraindicated because the patient may still have problems of epidural hematoma. So you always go for GA. Now, how do you go for GA for these patients? What are the things you will keep in mind while giving general anesthesia for these patients? Will you go for general endotracheal anesthesia or will you put a supraglottic airway device and manage?
Endotracheal.
Endotracheal
It is
integration.
still obstruction, so they might.
No, is it because the obstruction that is the obstruction has been relieved, but they want to take up?
Sir, we'll be considering that patient is full stomach, sir.
Yeah, always, end-stage liver disease patients, cirrhotic patients, they consider them to have full stomach, especially if they have ascites. Your patient also has got ascites. You should always consider them to have full stomach, and you may have to go for. You cannot put the supraglottic airway device because they are not 100% protection. They'll not produce 100% protection for aspiration. So always general endotracheal anesthesia. Okay, so you're planning for general endotracheal anesthesia. You've optimized this hemodynamic status. Sorry, not hemodynamic status, but you have optimized his hematological status, coagulopathy. Now, would you give him fluids before taking up? Because we know that they also will have hypovolemia.
Yes, sir.
Colloids are preferred more than crystalloids. Albumin 5% or 20% albumin.
Yeah, you may have to go for 5% albumin, isotonic 5% albumin. You can definitely give. That will help in maintaining the volume status before. Okay, and also you can start crystalloids. And you can even start because you said that these patients may also have hypoglycemia.
Yes, sir.
They may go for hypoglycemia intraoperatively. So you may have to even start about 5% dextrose also for these patients. So 5% dextrose, albumin, and crystalloids. So balanced salt solutions. So all these are started for these patients. Okay. Now pre-medication.
Anti-aspiration ranitidine 1 mg per kg can be given, or metoclopramide 10 mg IV can be given.
Okay.
We'll avoid benzodiazepines, sir. It's not like
No, you'll avoid totally, or you want to give the lower dose. Which benzodiazepine, if at all, if you want to give?
midazolam, sir.
Yeah, midazolam. Still,
Preferred.
midazolam is okay because when compared to diazepam,
Yes, sir.
midazolam and temazepam, they are still okay because their metabolites are not active. both temazepam and midazolam and lorazepam. Whereas diazepam, so it's even nordiazepam or desmethyl diazepam, which is a metabolite of diazepam, is also very active. And these patients are extremely sensitive for diazepam. So low dose midazolam you can still give. What is the dose? Low dose means how much you give.
0.05 mg per kg, sir.
0.05 is very high dose.
Sir,
Go for
0.0
1 milligram per kg body weight. Less than 1 milligram of midazolam you can definitely give. What about opioids?
we prefer fentanyl over morphine, sir, for these patients.
Pardon? Fentanyl or remifentanil?
Remifentanil.
So what about fentanyl?
Fentanyl can, if we have, so fentanyl can be used, sir.
Can be used, but lower dose,
Lower dose, sir.
isn't it? Because fentanyl also, the norfentanyl and fentanyl, they may have a prolonged duration of action because the fentanyl is also has to undergo metabolism in the liver. So definitely in these patients with chronic liver disease, fentanyl also can have a prolonged duration of action. So you may have to reduce the dose. How about remifentanil? How it is metabolized?
Remifentanil is metabolized through, it has.
How remifentanil is metabolized?
The first pass metabolism it has.
No, first pass metabolism for oral drugs. You are not giving orally.
Yes, sir.
That is why you should be extremely careful what you talk in the exam. Just to say something you do not tell, then you will have, everything will be towards the oral drugs and first pass metabolism. They'll start asking questions. So remifentanil is, organ independent metabolism. It is metabolized by non-pseudocholinesterase esterases. They'll metabolize, remifentanil in the plasma itself. So it does not depend on the liver for its metabolism. That is why remifentanil is okay. Definitely you can go for bolus dose and an infusion, continuous infusion of remifentanil for these patients. Okay, so what about dexmedetomidine? Can you use dexmedetomidine?
No, sir, dexmedetomidine should not be given, sir.
Should not be given, is it?
Sorry, alpha 2 imbalance should be given. This can be given.
You can still give dexmedetomidine, but lower dose. You have to reduce. Instead of 1 mic per kg infusion, you go for 0.5 per kg body weight as a pre-induction drug. Okay. What about lidocaine? Because you have to suppress the intubation response also, and you may have to use lidocaine. The same dose, 1.5 milligram, or you want to reduce?
Lower dose, sir.
A lower dose, because it has to be metabolized in the liver. What is the metabolic end product of lidocaine? What is MEGX? Monoethyl glycine xylidide. So actually, lidocaine is used to know exactly functioning of the liver and also about the blood supply to the liver by using the estimation of MEGX. That is one of the methods of estimating the blood flow and also functioning of the liver by giving lidocaine and estimating the MEGX, because MEGX is the metabolite of lidocaine. Okay, you have to reduce. You may have to go for 1 milligram per kg body weight of lidocaine. So what about the induction agent for this patient? Can you go for propofol, thiopentone, ketamine, etomidate?
Propofol you can use, sir.
No, you don't say propofol can be used. What you want to use?
So propofol, sir.
For induction.
Propofol for induction in a titrated dose, sir.
Now, when you want to avoid propofol?
In a hypotensive state if the patient is.
No, that is there. In a particular patient, already we have discussed about the effects of the chronic liver disease on the heart? I told you also then.
The hyperlipidemia.
If the patient has cardiomyopathy as a result of
Reduced
end-stage liver disease, you avoid, propofol. They'll collapse if the patient has got cardiomyopathy, isn't it?
Yes, sir.
So the patient, if you have ruled out cardiomyopathy by getting an echo done, definitely you can use propofol. Why propofol compared to thiopentone? What is the advantage of propofol over thiopentone?
So no residual effects, thiopentone.
No, but how propofol gets metabolized? How thiopentone gets metabolized?
Uh, the,
Next session, Mahal will be talking about propofol, the drugs. He told me yesterday.
Yes, sir.
No, don't answer, Mahal. Let them answer. How propofol gets metabolized?
propofol is metabolized in the liver, so
Entirely 100% it is metabolized in the liver. Does it have extra hepatic metabolism?
yes, extra hepatic metabolism in the lungs,
Lungs and
kidneys, sir.
kidneys. Because it has got extra hepatic metabolism, definitely the propofol is a preferred choice when compared to thiopentone. Thiopentone entirely it has to get metabolized in the liver.
Liver.
So propofol is one of the drugs definitely you can use. But again, the dose, depending on, you have to reduce the dose. So what you have to do?
Tighter doses.
How do you
Titrated.
titrate? You have to give a sleep dose,
Yes,
or
sir.
you have to continuously monitor.
Best morning.
BIS monitoring or entropy, anesthetic depth. Based on that, you can definitely give. Or how do you give the sleep dose?
10 mg, and then you have to ask for the loss of 10 incremental doses of 10 mg.
First, you calculate the total dose required. Usually required is about 2 milligram per kg body weight. Half the dose you give very slowly, continuously monitoring the eyelash reflex. And then you give 10 milligrams increments every 15 to 20 seconds, continuously monitoring the eyelash reflex or the response, verbal response. Once both are lost, verbal response and eyelash reflex, then you stop injecting the increments. That is all you always do. Okay. Now, what about the type of induction?
RSA, rapid sequence induction with
Rapid sequence induction, you have to go for in all patients with end-stage liver disease. Plus, I was telling you, this may be a patient may have intestinal obstruction. So it is always rapid sequence induction. So I'll not ask you how you go for rapid sequence induction, but what is the muscle relaxant you will be using for rapid sequence induction?
Succinylcholine will be used, sir.
Succinylcholine. So any problem of using succinylcholine in these patients?
Yes, so reduced doses we'll be using, sir, because in advanced liver disease, they'll have pseudocholinesterase.
Yeah, that is very good. So pseudocholinesterase levels will be decreased. So, but will you reduce the dose of succinylcholine? It may not act if you reduce the dose.
1 to 1.
Then, you will be struggling, and that is the time the patient will aspirate.
So atracurium cannot also be used as a...
No, atracurium is not the drug of choice for rapid sequence induction. Don't tell anything just like that, whatever that comes to your mind. You should always think before you answer. Okay. So succinylcholine is still the drug of choice. But you give 1 to 1.5 milligram per kg body weight, but you expect a prolonged duration of action.
Yes, sir.
You don't give non-depolarizer. Still the patient comes out of succinylcholine. Isn't it? Because you don't know how much, if you want to reduce, you don't know how much of a reduced dose you have to give. Suppose you give the reduced dose, it may not act. So it may take about 20-25 minutes for the patient to come out. So let him come out slightly late, no problem. You don't give non-depolarizer till then. Okay, so that is what you have to do. And also continue to monitor the neuromuscular junction. That is very important. So For that, you have to answer about what are the monitors you'll be using. So just tell what are the monitors you'll have to use for these patients.
Standard ASA monitoring, so
Okay,
BP,
standard ASA monitors.
for BP, heart rate, ETCO2, and SpO2,
Yeah.
ECG.
The patient is hemodynamically unstable. Invasive blood pressure monitoring can also
Very
be
good.
done.
So invasive arterial monitoring, arterial, cannulation and invasive blood pressure monitoring. Plus, you may have to use a central venous monitoring also. Provided all these things, you have to make sure that the patient's coagulopathy is nearly treated.
Yes, sir.
So using ultrasound definitely will help even in these patients with coagulopathy. So better to go for invasive monitoring.
Yes.
So better to avoid transesophageal echo because you may expect the patient to have esophageal varices.
Can be
Yes,
done.
sir.
So these are the monitoring is very important. So neuromuscular junction monitoring is also one of the important things. You have to do it. Okay. So then rapid sequence induction and intubation. So you've intubated the patient. Now, how do you, what another muscle relaxant you will be using for maintenance?
Atracurium can be used.
Yeah, why not rocuronium or vecuronium?
It will be metabolized in the liver, sir.
Yes, very good. So vecuronium and rocuronium are metabolized in the liver and excreted through the bile and also through the kidneys, unchanged also some amount. So it is better to go for a drug which does not require liver for its metabolism and excretion. So how this atracurium or cisatracurium are metabolized?
Hoffman's reaction.
A Hoffman's elimination. So temperature and pH dependent degradation of the drug is Hoffman's elimination. So you can definitely use. And what about the initial dose? Do they require higher dose or they require lower dose initially?
Initially, higher dose is required, sir, but maintenance
Very
is lower.
good. So why initially higher dose is required?
Increased volume of distribution is there, sir. So initial requirement will be high, but since they have an increased free fraction of the drugs, you will have to titrate it later. For giving.
Okay. So why what increases the volume of distribution?
Plasmic vasodilatation and also
Splenomegaly is there, ascites is there. So these two itself will increase the volume of distribution, the splenomegaly and ascites. So that is apparent volume of distribution will be increased. So initial dose may be required higher dose, but when you give a higher dose, the patient will not come out so easily.
Yes.
The duration of action can get prolonged even with atracurium and cisatracurium. So you have to be careful, isn't it? So how do you ventilate these patients?
halothane and nitrous oxide are avoided. We have to
Ventilatory settings.
Why nitrous oxide you want to avoid?
Vasodilatation. Patient is already having
Nitrous oxide will not produce any vasodilatation. It may increase the pulmonary vascular resistance. So if a patient has got portopulmonary hypertension, you avoid nitrous oxide. Otherwise, you need not have to avoid. But in a patient with intestinal obstruction, definitely you will try to avoid nitrous oxide. But otherwise, nitrous oxide does not reduce the hepatic blood flow much. That is also you'll have to think about. So if you want to avoid, you can avoid. Okay, so what about other inhalation anesthetic agent? Which inhalation anesthetic agent you would like to go for?
desflurane.
Desflurane better to avoid because it can increase pulmonary vascular resistance or usually and it can produce tachycardia and hypertension also. So many times ideal would be to go for sevoflurane or sevoflurane. One thing you may, why you must have thought about desflurane is because early recovery.
Yes, sir.
fluorine because its blood gas solubility coefficient is,
Yes.
less than, it's around 0.4, isn't it? So that is one thing which may go with the desflurane, but ideal would be to go for sevoflurane or isoflurane because both will not reduce the hepatic blood flow. Okay. So how do you ventilate?
Ventilatory settings of tidal volume of 6 to 8 ml per kg with EtCO2 should be maintained between 35 to 40 mm
Hg and PEEP of 5 to 8 centimeter H2, like lung protective mechanism should be there.
Yeah, lung protective ventilatory strategies. This is called as lung protective ventilatory strategy. You have to adopt. And intravenous, the IV fluids and volume status.
CVP.
CVP is a static, thing. It is not a dynamic parameter.
The balanced salt solution will be using, sir.
No. What parameters you will be using?
Pulse pressure variation, sir.
It is very challenging to manage the fluid status in these patients, but still you can use dynamic parameters like stroke volume variation,
Pulse
then
pressure
pulse pressure variation or systolic pressure variations. All these things you can definitely use it. Okay, now how are you going to reverse this patient?
using and
Now, how this mean? No, I told you that you don't murmur and you don't talk to each other like that. You answer. I'm asking you a question. You should answer. Normally, if you're giving atracurium, what reversal agent you would be using?
Neostigmin and glycosylate.
Can you use Sugammadex?
Yes, sir.
Yes,
Not.
for atracurium, atracurium.
No, sir.
See,
No, sir. No, sir.
Sugammadex is only for aminosteroid non-depolarizing muscle relaxants like vecuronium or mainly for rocuronium. So atracurium it will not help.
Yes, sir.
Isn't it? Suppose if you had given vecuronium or rocuronium, then you could have used Sugammadex, definitely. That is not contraindicated because it is not metabolized by the liver. It is only excreted through kidneys. So it's not contraindicated, Sugammadex. But because you have used cisatracurium or atracurium, so you can still reverse the patient using glycopyrrolate and neostigmin. How the glycopyrrolate and neostigmin are metabolized? Do they require liver for their metabolism? See how questions can be asked for you in the exams. Now, both neostigmin and glycopyrrolate, 50% of the drug is metabolized in the liver, 50% is excreted unchanged through the kidneys. So when you're giving the regular dose, what will happen? Because they have to be excreted only through kidneys. What happens to the duration of action?
Increased, sir.
Yeah, it will be prolonged. But the duration of action of both neostigmin and glycopyrrolate will be prolonged. There is no problem. Isn't it? Both are prolonged. So definitely they can be used. So that's how you can answer. And about post-op pain management, how are you going to manage the post-op pain?
We can, for this patient, we can give paracetamol also, sir, and at a reduced dose.
For a patient with end-stage liver disease.
At a reduced dose, we can give, sir.
Paracetamol is usually one of the hepatotoxic drug, isn't it?
Yeah.
It's an hepatotoxic drug.
Yes.
Ideally speaking, you may have to avoid, isn't it? So it's very difficult to manage the post-operative pain. You may have to use continuous infusion of remifentanil or a patient-controlled IV analgesia using remifentanil. Of course, tap block you can use, but again the problem of how much of local anesthetics. So you can still use tap block. Tap block can be given. Local infiltration of local anesthetic also can be done, but continuous infusion of remifentanil. So you have to be cautious about non-steroidal anti-inflammatory drugs because their effect on the kidneys and their effect on the, the platelets. So you have to be careful, isn't it? It's quite challenging, even post-op analgesia. Everything is challenging in these patients.
Yes, sir.
Okay, that is about anesthesia for the end-stage liver disease. Let us also discuss about you can have a patient with obstructive jaundice, posted for Whipple's. You have given anesthesia for Whipple's surgery?
Yes,
No,
sir.
cholangiocarcinoma or even, head of the pancreas malignancy. Usually they are posted for Whipple's surgery, a prolonged surgery where you expect a lot of bleeding. So in these patients, now how they are different from end-stage liver disease? Obstructive jaundice.
Sir.
What about the liver functions?
Liver function test will be normal, sir.
So cellular integrity functions are normal. It may not be much change. AST, ALT will be normal only. Liver functions will be normal. Only increased is alkaline phosphatase, GTT, and the 5-nucleotidase. They are increased, isn't it? So since the liver functioning is normal, you can use all the drugs, whatever the drugs you want to use. Only thing is slightly you have to reduce the dose. That's all. Otherwise, use all the drugs in patients with obstructive jaundice. That is one thing. Second thing is these obstructive jaundice patients will have a high level of, the bilirubin. So you may have to subject them for the ERCP, endoscopic procedures to, open up the, if there is obstruction so that the bilirubin levels can come down. That is another thing. The third important thing is they are highly prone for infections. So you have to give antibiotic coverage. And fourth thing is you may have to give vitamin K supplementation because you know that their vitamin K absorption is not occurring. So you have to give vitamin K. And what about the use of opioids in these patients as pre-induction drugs? Can you use opioids?
Opioids can be used.
So what is the effect of opioids on the sphincter of RD?
So it will cause constriction.
So what will happen to the patient when you are giving? Patient can definitely develop severe abdominal pain. So in such situation, you have to give glycopyrrolate first or atropine first, relax the sphincter, and then use opioids. That is another very important thing you should always remember about. And also consider these patients. And one more thing they can go in for is tubular necrosis. Acute tubular necrosis is more common there rather than the pre-renal failure in these patients. Because the endotoxins that are released are usually metabolized in the liver and it has to be taken up through the enterohepatic circulation. Now, the enterohepatic circulation may not be occurring in these patients. And the other thing is the cholestasis. Again, these endotoxins can get released into the circulation because the Kupffer cells, which are the ones which, detoxify these endotoxins, will not be effectively functioning. So these endotoxins can directly produce acute tubular necrosis. So you will have to make sure that this does not occur. You have to increase the amount of urine output for these patients. So how do you make sure that the urine output is good and more than 1 ml per kg per hour preoperatively for these patients?
Catheterize the patient.
Diabetes.
You have to monitor the urine output, isn't it? And if the urine output is more than 1 ml, you can encourage them to take oral fluids. Till 2 hours before, you can encourage them to take oral fluids, isn't it? So that produce increase in urine output. If they are, the urine output is less than 1 ml, but above 0.5 ml, you have to give additional intravenous fluids also to increase the urine output. If it is less than 0.5 ml, you may have to give even mannitol to improve the urine output so that urine output is more than 1 ml per kg. So that is another important thing in preparation of these patients. You have to take care.
Yes.
Otherwise, intraoperatively, you expect blood loss, more blood loss because Whipple's prolonged surgery. So you will have to keep ready the the products, blood products, and also you have to go for invasive monitoring. And use of vecuronium, rocuronium are not contraindicated. You can still use because liver functioning will be normal in these patients. You need not have to go for atracurium or cisatracurium.
Yes.
Okay, so these are some of the differences because, and one more very important thing we forgot to discuss is the assessment of these patients using, child Tarkat-Pukes criteria, isn't it? So that we should have discussed. Can you just tell about child Tarkat-Pukes criteria for assessment?
Based on serum bilirubin, ascites, albumin, increased prothrombin, and encephalopathy. There are three scores: point 1, 2, 3. Bilirubin level of less than 2 is 1 score. 2 to 3 is 0.2. More than 3 is 3 points. Then presence of albumin more than 3.5 is 1. 3.5 to 2.8 is 2. Less than 2.8 is 3. Then prothrombin 1 to 3 seconds, 4 to 6 seconds, more than 6 seconds is 3. Prolongation.
INR?
INR not in.
Up to 1.7
Yes, sir.
is 1.7 to 2.3, and anything above 2.3 is 3 point. And
Yes.
about encephalopathy?
In the first point, there is no encephalopathy. There is grade 1 to 2 in the second point, and 3 to 4 in the third point, sir.
Okay. About ascites?
There is no ascites in point 1, slight to
Minus.
moderate, mild to moderate.
Well-controlled ascites, poorly controlled ascites. That's all. Well-controlled is 2, poorly controlled is 3. So now, based on the points, how do you assess the mortality risk?
5 to 6 means it is a grade A, less than
7 to 9
and
10 and above.
Yes,
Isn't
sir.
it? So 10 and above. And these patients, if they are 10 and above, so they may not be fit for any elective procedures, isn't it? So the high mortality will be there. So otherwise, for liver transplant, what is the latest thing they use other than child Tarkat-Pukes? MELD score, isn't it? Model of end-stage liver disease. What are the criteria that are used in MELD scoring?
Serum creatinine levels, then INR levels, serum bilirubin levels.
Okay. Okay. So PELD scoring is also there. That is for pediatrics. So this we should have discussed. Okay. Anyway, now we had forgotten to discuss and we have discussed. Okay. So this will be the complete discussion regarding the near complete discussion of the liver and anesthesia. So you said that you had some doubts.
Yes, sir.
What
Yes, sir.
doubts?
Actually, if with the deranged INR, even if they have an INR of 1.6, but the patient is DCLD, can we still proceed with a spinal anesthesia for the patient?
No. Anything above 1.5, absolutely contraindicated. Spinal or epidural or whatever it may be, regional anesthesia are contraindicated. Ideally, you don't go for it. Ideally speaking.
Okay, sir.
So that is ruled out. You have to go for GA, or you try to correct. Even if after correction, better. If the hemoglobin, for example, INR is more than 1.5, but the patient has obstructive jaundice. So you give vitamin K. Now INR has come back to normal. Then you can definitely go for epidural because Whipple's you usually go for an epidural also for post-op analysis. It is not contraindicated, provided the INR is within normal limits. The platelets are more than 50,000, more than 80,000. Definitely you can use it.
So, and for pain management, we can give fentanyl patch also, sir.
Fentanyl patch you can give, but again, the fentanyl has to be metabolized, whether it is a patch or oral or nasal or intramuscular or intravenous, it has to be metabolized by the liver. There can be prolonged effect, and especially the respiratory depression part we are bothered about. Still you can use. Definitely you can use. So any more doubts?
Urine output, if it's decreased, we can give a furosemide and improve it.
Yeah, you can. Definitely, you can improve. But the thing is, these patients may have hypovolemia. And if it is due to hypovolemia, further reduction of the volume will occur. It is always better to give fluid boluses and then see urine output will improve or not, instead of going in for furosemide. Okay, furosemide is only used when there is ascites is there. In order to reduce the ascites, there you use furosemide, not for the patient is having an oliguria as a result of hypoperfusion. That will further decrease the perfusion and that may produce more problem, isn't it? So in such situation, the volume status has to be improved. So you may have to give albumin. You may have to give again, compress the splanchnic vasodilatory states by giving terlipressin or octreotide or any of these things you can give. And that will actually improve the urine output. Don't give furosemide for improving the urine output.
Yes, sir.
The inotrope of choice for DCLD patients.
Inotrope, definitely norepinephrine, still the choice. You can go for. But one thing you should always remember that their effectiveness may be blunted. So they may require slightly higher dose to get the same effect. So that is one thing, because advantage of norepinephrine is splanchnic vasoconstriction it produces. So that is the advantage. That's how terlipressin or norepinephrine, any one of them you can use. Okay, then what is the time? I think exactly 7.
Yes, sir.
And no doubts in the chat box. I'm not finding anything in the chat box. So anyway, we will call it a day.
Yes, sir.
Okay, today you are much better when compared to yesterday, but don't murmur when you want to answer.
Yes, sir.
In the exam also the same thing. You know the answer. If you know the answer, you answer it. And
Yes,
here
sir.
there is no problem. This is not an examination. You should have answered loudly, isn't
Yes,
it?
sir.
And boldly. Because this is not an examination.
Yes,
Even if
sir.
you are wrong, there is no problem. Anyway, I am there to correct. Isn't
Yes,
it?
sir.
So, but try to, give importance to case discussions. Present as many cases as possible in your to your teachers. Don't hesitate in presenting cases. You will become bold. You will become more positive in your answering, and you will be more confident. So keep
Yes,
doing
sir.
presentations.
Yes,
Case
sir.
presentation. So
Yes,
if
sir.
you have to present again once more in our discussions, you come back and then present.
Yes,
Yes,
Okay.
sir.
Volunteer yourself. That
Yes,
will
sir.
definitely improve your confidence levels so that you will not murmur
Yes, sir.
or you will not whisper to yourself. You will boldly be answering. Okay.
Yes, sir.
All the best.
Thank you,
so
sir.
much, sir.
Thank
Thank
you.
you, sir.
So let me leave. Okay, Mahal. We'll meet after 15 days.
Sure, sir. Sure, sir. Thank you so much.
Okay,
Thank you,
Mahal.
sir.
Bye.
Thank you, sir.